Hello, Prynhawn da, Prynhawn da, croeso. Hello, good afternoon and welcome. I'm Darren Hughes. I'm the Director of the Welsh NHS Confederation. Welcome to today's Welsh NHS Confederation Wellbeing for Wales lecture. Today we're privileged to have an excellent panel of speakers to talk about place-based care in action in Wales. Before we say any more, just a few housekeeping points to make. Just advised all participants, as well as delegates, to keep microphones on mute and cameras turned off for the duration of the event. Today's meeting will be recorded. If you could submit questions in the interactive panel discussion at the end via the chat function, we'll do our best to answer all of the questions for you today, but if not, we will follow up with email. As well as this event, today we have a similar event on a different topic on 14th of July next week, why good housing is essential to health and well-being. Improving the health of the population health is a key plank of our work at the Welsh NHS Confederation for the next 12 months. There are no Wellbeing for Wales lectures during August because of the holiday period. And one final plug for our work, the Welsh NHS Confederation Annual Conference and Exhibition will take place on the 13th of September at the All Nation Centre in Cardiff. This is the first one in person, face-to-face since 2020, and we look forward to welcoming delegates, exhibitors and sponsors in person in September. And we've already got an excellent programme for that event. Today's session will provide a brief strategic overview of place-based care before undertaking a deep dive into place-based care in action in Wales. The session will provide an insight into how place-based care is working across Wales and linking it to the aspirations set out in the government's programme, A Healthier Wales, and the programme for government. We're going to explore what can be achieved by working together to deliver the aspirations of the primary care model for Wales. Our speakers today are Sue Morgan, National Director, Strategic Programme Lead for Primary Care, Dr. Karen Gully, National Professional Advisor on Accelerated Cluster Development, Will Beer, Assistant Divisional Director, Primary Community Care, and Irene Bevan, University Health Board, Kerry Phipps, National AHP Lead for Primary and Community Care, and Sarah McCarthy, Director Improvement and Development of Social Care Wales, will join for the interactive panel discussion. I'd like now to hand over to Sue, who is going to give a few more words of introduction and give a new overview of the individual sessions. Over to you, Sue.
Many thanks, Darren, and many thanks for the opportunity to talk about this today, and for everyone who has given us the time to join today, because I know finding time in a very busy schedule is very difficult, so we hope to make the best of this time. I can only see the holding slide. I just want to check that the presentation's rolling.
At the moment, I can only see the holding slide, but I can now see the presentation.
There we go. Thank you. Thank you very much. So the next slide, in terms of just to run through what the schedule of this session will be. I'm just going to give a brief overview and kind of context of the wider strategic programme to begin with, and then I'll hand over to Sarah McCarthy, who's the Director of Improvement and Development in Social Care Wales. Dr. Karen Gully will give us an overview of the primary care model for Wales and the Accelerated Cluster Development Programme. And then we're going to get various different lenses on cluster working and the Accelerated Cluster Development Programme. Firstly, from Will Beer, who will talk about cluster working in action. And then from Kerry Phipps, from an allied health professionals perspective, and Chiquita Cousins from a nursing perspective. And also bringing in what does it mean in terms of the community infrastructure programme and how that will support place-based care, something that both Kerry and Chiquita are leading on. As Darren said, we'll then have opportunity to have a wider discussion through an interactive panel discussion, and we look forward to your questions at that point. So the next slide, please. Thank you. So I suppose the first question I always want to address in any discussion like this is, what is primary care? So primary care is often regarded as GPs, and sometimes regarded as a bit wider than that. So GPs, dentists, community pharmacists, optometrists, so your high street health. But actually, from our perspective, how we regard primary care is in the absolute widest sense. So we think about what is in the community, what is out of hospital, what care can be provided as close to home as possible, but also really thinking about how we equip the citizen to really look after their own, build their resilience, build the resilience at community level, and look after their own health and well-being. The actual strategic programme for primary care is an All Wales Health Board-led programme that works in collaboration with Welsh Government, and as Darren said, responds to a healthier Wales. But we're really keen to emphasise today that it's our lens on delivering the primary care component to place-based care. And the way we organise ourselves in the programme is across 6 work streams, and that's what you'll see in the right-hand corner there. We have 6 work streams, the first being prevention and well-being, the 24/7 model, data and digital technology, workforce and OD, comms and engagement, and transformation and vision for clusters. And that's how we actually push our work programme through in terms of what we're doing within the strategic programme. Last year, we agreed a number of priorities, 4 priorities, and that was all based on care closer to home and moving forward with that place-based care approach. And those 4 were mental well-being, and certainly during COVID and particularly the pandemic and lockdown, that came into sharper focus for us in terms of what we needed to do there. And we're looking at what that kind of tier 0, tier 1 approach is at cluster level. Urgent primary care, and that was about looking at, yes, we have urgent primary care during the day, so the core hours, and we have 111 out of hours, but was there a separate offer that we could think about in terms of urgent primary care centres, which provides an additional alternative into urgent care? Community infrastructure was our 3rd priority, and that's really thinking around the community services that we provide and getting to kind of a minimum offer, a standard offer in Wales of community services. And then finally, accelerated cluster development. For me, this is the structure that we're putting in place to ensure primary care can be absolutely part of place-based care and join up the discussions with all of our stakeholders as well. So that's what the deep dive is today on accelerated cluster development, and we're also going to touch on how community infrastructure works with that. But before we get into the detail of that, I'm going to hand over to Sarah McCarthy, who's going to say a few words.
Cynnada pawb. I just wanted to offer a few words on behalf of Social Care in Wales. I work for Social Care Wales, and we're the organisation who is responsible for workforce regulation, workforce development, research, innovation and supporting service improvement in social care, working closely with our colleagues across the social care family. And social care, like primary care, is delivered in every single community of Wales. We've got a workforce of around 90,000 people working really closely with individuals and families. And I wanted just to rewind back to the Social Services and Wellbeing Wales Act, which really sets out the legal framework for improving the wellbeing of people who need care and support and their carers. And that's got a number of key principles. Voice and control, so put an individual and their needs in the centre of their care. Prevention and early intervention in the community to minimise the escalation of critical need. Wellbeing, to support people to achieve their own wellbeing. And co-production, so encouraging individuals to become more involved in the design and delivery of their services. So we can see the legislation is about much more than social services, and it absolutely supports our discussion today and the ambitions in a healthier Wales. So as you listen to the presentations that follow, you will see how the links to accelerated cluster development fit with the ambitions for social care, and how with citizens, local authorities, private and third sector, we can support local delivery and provision. The Association of Directors of Social Services have been engaged in work on accelerated cluster development, and they've confirmed they're absolutely committed to the development of more integrated models and to that end, effective integrated planning with partners. We want to make sure that we've got integrated planning and delivery in communities so that we can ensure individuals and families can focus on what matters to them, and embedding those key principles I mentioned: voice and control, prevention, wellbeing and co-production. Primary care is crucial to prevention and wellbeing and ensuring that we have an effective and enabling care and support pathways. For individuals in our communities, partnerships across citizens, primary care, social care and the third sector can create resourceful and resilient communities that give more timely and effective support, but also reduce reliance on maybe traditional support or the need for secondary care. So in dialogue with my colleagues in ADSS, we feel that social care has a key and a significant contribution to effective place-based care. The work we see with community connectors, integrated teams, micro-enterprises, social enterprises, community support, and a significant workforce working with all of our individuals and communities means that we've already got in place many areas where we can support further collaboration. If we can listen and respond to the needs of population and work collaboratively, then we feel we can achieve more effective care and support in all of our communities. So we offer the opportunity to join today, and I'm now going to hand over to Dr. Karen Gelly.
Thank you very much, Sarah. That's great. And I think it's really helpful that we've already talked about the importance of work on housing and social care, which from a medical primary care perspective is absolutely critical for what we're trying to achieve. So this is all very much about our whole system and partnership approach. So I'm going to talk a little bit about the principles of the primary care model and the work that we're doing to try and make this work go further and faster. So cluster working's been in Wales for over 10 years, and many of you will be aware of the work of Setting the Direction, which was a really big piece of work looking at how our systems worked and what we needed to do to meet the needs of the public and patients and carers much better. For me, it also goes right back to some of the core principles about public service, which were described by Professor Julian Tudor-Hart of Inverse Care Law or fame. And he talked about a sense of place, about the importance of place and community, and also how our workforce become experts in the communities they serve. And critical, I think, for cluster working is that knowledge within a local setting. So clusters are the local footprint for delivery. And I think it's reasonable for the public to expect that all of our services work together at that level. And if we're going to do that, we all need a shared understanding of the needs of each community. There's a wealth of knowledge held within those communities, but also our workforce has a huge amount of intelligence. And then there's formal public health analysis, which we bring to that work. This two-way process, though, of course, the more information that we can give to the public, we allow them to make more choices, to agree local priorities, and to build on the local skills and opportunities. And a critical thing about the scale of cluster working was it could get into the detail. There could be personal relationships to look at ways to solve problems, and the people on the ground would know what works in that situation. So clusters were created, they were given budgets to test new solutions, and they've created a rich patchwork of models of care that we can test out. And that means that we can respond to the needs in rural communities, inner cities, and in the post-industrial areas as well, to fit the gaps and the challenges that are real now. And all of this work remains a priority in Programme for Government, A Healthier Wales, and in the ministerial priorities. And it's really central to delivering the ambitions of the regional partnership boards. So the work had been going on, as I mentioned, for 10 years. And so at the height of the second wave of the pandemic, which is obviously a brave piece of work, Alan Laurie led the cluster survey, because we really wanted to understand what was working, what we could do to make things progress further and faster. And there was a general sense that this was the right direction. It had produced really great examples of good practice. But if we wanted to really make the change that we all want, we had to go further and faster. And that was about engaging our whole workforce and more positive engagement with the community, and a really important links with our local authority colleagues and third sector to deliver that change. So if I could go on to the next slide, some of the work that we've talked about, as you see on this slide, is really showing the level of detail we can get into when we're talking about a population somewhere between 25 and 100,000. And we get very, very focused areas where they're highly populated, and then we cover much larger areas in rural settings. The next slide shows the clarity of purpose that the survey really called out for, which is what are we trying to deliver? And the primary care model describes that in its 13 outcome areas. And it's very much around the principles of information for the public and empowerment for the public, and bringing things closer to the people that we serve. We also know that for seamless working, we as services need to find ways to work together. And that means different levels of our system need to create the right environment for the workforce to be able to do that. As mentioned earlier, this only works if we've got solutions that work 24/7 and 365 days of the year. But we're also looking at how we can make services more directly accessible to people and more integrated. And all of this depends on the big structural things like estates and finance actually being lined up around the work that we're doing, making communication and data sharing easier, making it easier to access diagnostics, and allowing the people at the front line to deliver the change that they see needs to happen. So our next slide talks about the Accelerated Cluster Development Programme. You can see it's busy. We need to do a lot to help to make this work go further and faster. We've looked at changes in the architecture. Our survey told us that we needed to have space for individual professional groups to meet together to sort out problems that were distinct for them. But we also needed to be able to influence in the system. We needed messages to get up to influence strategic planning and delivery. And that's where pan-cluster planning groups come in. They're at a slightly larger footprint, but that allows us to make those significant strategic changes that make things easier to deliver on the ground. It's a bigger footprint, but it's close enough to be sensitive to local context and communities. Our next slide shows the transition year timelines and deliverables. We're very serious about this being a program that delivers change. It's not a conversation or a talking shop. It's about having timelines and deliverables. And as the strategic program, we're listening to what people are telling us about how things work on the ground. We're looking at what we can do nationally, what barriers need to be addressed. And we're holding a peer review cycle towards the end of the year, which again informs the reality of putting this into practice and realizing the change that people need. Our next slide shows how this works in practice. You can see that it's busy. It is a complex system, and I think it's important that we recognize that, but make it easy for our workforce to work through it. The critical things for me is that this is about a dynamic problem-solving system, and you can see at the bottom left is the conversation in the community. It could be a patient, but it could be someone using any of our public services. And there's lots of opportunities to solve problems at a local level. And one of our jobs is to try and make sure that we delegate powers for that to happen as much as possible. But where that needs to be escalated, we provide a clear structure for issues to be brought up the system and solved at different levels. But the critical thing is that then delivers change back in the community around individuals, carers, and our workforce. And a critical part of our work is recognizing that the experience of our workforce is absolutely vital for recruitment and retention. We have to help people to do the job that they want to do. Our next slide looks at the underlying purpose. As I said at the beginning, there's a really shared vision around this work. We feel it's the right thing to do. And I think bringing it back to the principles is always helpful, because there is evidence around the approach that we're taking that will improve outcomes for our citizens, which is what we're all here to do. We know that there is strong evidence that if we can improve access, maintain continuity, provide comprehensive care, and coordinate the care that we provide, that we improve the uptake of preventive measures, we improve the delivery of care, and we help people to achieve better outcomes and the outcomes that are right for them. And so all of the work we're doing is about enabling those things to happen. So that's the theory underpinning our approach. It's obviously sometimes much more difficult in practice, but I'm going to hand over to Dr. Will Beer, who is Assistant Divisional Director in Primary and Community Care in an Aneurin Bevan Health Board. And he's going to talk about how this is really being delivered in practice with fantastic successes and also some of the reality and challenges that are faced. So over to you, Will.
Thank you, Karen. Can you hear me? Okay. Yeah, good. So good afternoon, everyone. So as it says on the slide, my name is Will. I'm a consultant in public health, but I was formerly a cluster lead working in Newport East cluster, and been recently brought into the role as Assistant Divisional Director for Primary Care Community Services. Just a little bit of background about an Aneurin Bevan Health Board. We've got a population of around 600,000. That covers 5 local authority areas. We're a large organisation. We employ 14,000 staff. Within the health board region, we have 11 clusters, 5 community hospitals, 5 frailty teams, 14 community nursing teams. We've got 4 mental health units in the community, 3 enhanced local general hospitals, and a relatively new specialist and critical care centre at Grange University Hospital. The area itself is kind of I suppose the Aneurin Bevan region is a bit of a microcosm of Wales. So we've got the 3rd largest city, Newport, with a population of about 160,000. We've got communities across the South Wales valleys, and we've also got rural agricultural Monmouthshire. So we're quite diverse in that kind of microcosm of the rest of Wales. We have a regional partnership board for the region that brings together the health board with the 5 local authorities and third sector to ensure that we're actually meeting the care and support needs of our local population. So if we can move on to the next slide. In addition to what Karen has talked about in terms of the primary care model for Wales, we've also been looking at what's happening outside of Wales. So we've looked at some of the work that's happening over in England around the 10 high impact areas that improve effectiveness and efficiency of primary care. And you can see those on the right hand side of the slide. We've been looking very closely at what's happening up in Glasgow through the work's been led by Professor Graham Watts around the Scottish Deep End project. We had Professor Chris Bentley come over to work with us from the Health and Inequalities National Support Unit. So with that population of 600,000 and being a microcosm of Wales, we've got significant health inequalities across the region. And I've also been influenced by the magnificent Julian Tudor Hart, who described the impact of the inverse care law in our communities. Bromley by Bow, I've been up to East London to meet with Sam Everington to look at the Bromley by Bow Centre, which has really developed a very community-orientated model of primary care. And also Dr. John Robson, who's a primary care clinical director up in Tower Hamlets, and some of the stuff he's done to drive improvement through managed clinical networks. Also been following the RCGP program down price at scale and some of the international models like Canterbury and Nuka. So next slide, please. So some of the achievements, some of the things we've done through our 11 clusters in Aneurin Bevan. So there's been a lot of focus on some of the population health issues. So we've been trying to address things like smoking cessation. We're just about to roll out our weight management, level 1 weight management program and diabetes prevention program up in Caerphilly North and Blarney Grant West. Some of our clusters, particularly in the centre of Newport, where we've got a large minority ethnic community, have been looking at screening inequalities. And we've been also using the clusters to drive improvement in our flu vaccination uptakes. We've worked with Welsh Government quite a few years back to look at the inverse care law, and we launched back in 2014 our Living Well, Living Longer programme to try and address cardiovascular inequalities on a cluster footprint. We know that the pandemic has really damaged people's mental health, so mental well-being is a big focus for clusters at the moment, and we've recently launched our Mellow website that brings together all of the provision around people's mental well-being into a single place, and that's right across the statutory and third sector, as well as some really useful resources that people can access online. And we've been rolling out Connect 5 for frontline staff, so they can have a conversation with people about ways to improve mental well-being at this difficult time. There's a sister program to Clusters, which is our integrated wellbeing networks. This is about trying to bring together all of the community assets on a place basis, and allows us to do much more social prescribing. So if patients are presenting in primary care with non-medical issues, that they can be supported to access other things, other wellbeing activities and support in their local community. We've used cluster funding to introduce psychological wellbeing practitioners. These practitioners can spend 45 minutes with a patient to come up with a formulation and a plan to improve their well-being and prevent their mental health needs escalating. We've done quite a bit of work around care navigation, so moving away from GP receptionists to care navigators that can make sure that when people contact the system, they are directed to the right support in the right place at the right time. We've invested in practice-based pharmacists to work alongside GPs, and the clusters have funded some directly accessible services, things like direct access physio. And last year, we started looking at the group of patients who are most at risk of admission and how we can provide sort of safe alternatives to provide their care and manage their care in the community. On the right-hand side, I won't go through this into too much detail, but you can see that it's not just about service developments and some of these programs, it's all about new ways of working. So as Karen said, it's understanding what the needs of the population are, where the gaps are. We've been running a number of IQT projects. We do a lot of work around medicines management, taking advantage of the digital revolution and how we can optimize the use of digital technology to keep people safe and well at home. Our virtual wards and our MDT meetings for the more complex patients. And we've currently rolling out a program of a new way of neighborhood nursing, of district nursing, building on the Buurtzorg principles. And then each of our cluster leads, each of the 11 cluster leads also have a link with a secondary care specialty, so we can make sure that if people do need secondary care services, there's a clear pathway for them. Next slide, please. So if you want to find out a bit more about what we've been doing, not just in Aneurin Bevan, but across the rest of Wales, please have a look at the Primary Care Cluster Yearbook that was published in 2019 on the back of the National Primary Care Conference. And there's lots of other examples from other regions in Wales. And we're now going to, I think, show a little video so you can hear a bit more from the people who are actually doing the work right at the front line.
Keir Duffin, I'm Head of Regen Investment and Housing for Newport City Council. This particular development has been in partnership with Aneurin Bevan Health Board and Newport City Homes, making up a regeneration package of around £50 million. Around about a quarter of the customers accessing a GP surgery should be coming to a community facility. A lot of things like financial difficulties, housing difficulties, low-level drug and alcohol challenges. What we need to make certain is that we deliver those services within the hub, and we do that with a mix of health and community services. This is a key project for the council, a key project for the Health Board and Newport City Homes, and although it being a challenging experience, it's been a very fruitful experience, and we look forward to working with the Health Board to make this a success I know it will be.
Hi, I'm Kelly Yem, Practice Manager at Beechwood Surgery Newport. NCM funding was provided to GP practices here in Newport to help train our receptionists to become care navigators. So this is about listening to patients, supporting patients' needs, and giving them more information about services and support that may be available for them. We have worked with local providers within the NCN to develop 16 pathways, such as Choose Pharmacy, Urgent Dental, WEC, Direct Access Physio, Mental Health, and First Contact, which gives people an alternative to seeing their GP. This is great for patients, and GPs feel it frees up time to assess people with more complex needs. I'm Dr. Sarah Morgan. I'm one of the partners in Ringland Health Centre. We decided some time ago to, in order to provide the right care for our patients, we needed to skill mix. In order to do this, we wanted to have first contact practitioners, physios and CPNs. Our NCM lead was instrumental in facilitating the conversations with the primary mental health teams and physiotherapy teams. We believe this will achieve better outcomes for patients, less medicalisation, and less, therefore, unnecessary work for patients and for ourselves. I think we have shown that we've decreased referrals to secondary care, improved patient outcomes. It's also been very useful to share the knowledge and the learning with our other colleagues that they can do similar, not the same projects in their own practice. And that's been for us the benefit of the network cluster arrangement.
I'm Sandra Tomato, and I'm the Community Strategy Partnership Manager for Newport City Council. Over the last few years, Newport City Council has been developing an integrated pathway with the NCM East and Age Cymru. The pathway works with patients that would benefit from preventative support. They work with Age Cymru care facilitators to develop and co-produce a Stay Well plan. This allows us to target our IAA at the people who would benefit from it most. Some of the patients then have support from the community connected to strengthen their social support network.
Hi, my name's Jude Davis, District Nurse Team Leader for Central East District Nursing Team in Newport, one of the pilot sites for neighbourhood nursing. The Bird Park model is a neighbourhood-based system of district nursing care with a focus on continuity of care delivered by a small team of nurses and giving district nurses more freedom and time with patients. We've made lots of changes to the way we do things over the last 12 months, but the care range training we received was particularly transformative. We've developed a specialist role required to support patients at home who would previously have been transferred to other specialist services. We understand and know our community really well, and we've got good relationships and informal networks within the local community.
Hello, my name is Trish, and I'm the manager of our Community Resource Team in Newport, commonly known as Newport Frailty Service. There are 6 teams in our service: Rapid Medical, Rapid Nursing, Physiotherapy, Occupational Therapy, Prevention and Management of Falls, and also a Reablement Care Team. Over the last 12 months, there have been some exciting developments. Our Rapid Medical and Rapid Nursing service now accept referrals from advanced nurse practitioners and advanced paramedics. Medical and nursing clinics are now available for our patients at St. Willis Hospital. This means that they have rapid access to medical consultants and specialist tests without being admitted to hospital. Our physiotherapy and reablement care service reach into wards to try and reduce delays in hospital discharge. The health and well-being of patients is at the heart of what we do. Attending Newport East NCN meetings is vitally important to the development of our service.
Okay, if we could move on to the next slide, please. Just while we're doing that, you will have heard some of my colleagues referring to NCNs. NCNs are neighbourhood care networks, and that's the term that we've used to describe our clusters across the region. So when you hear NCN, just think cluster. So where we're going next in the region, we've received funding from Welsh Government to really accelerate the delivery, more planning and delivery through clusters. So we're in the process of developing what we're calling our engine room to drive more delivery through our 11 clusters. We are really keen to move much more towards a kind of population management approach. And Karen referenced the primary care, the pan cluster planning groups. We referred to those as integrated services partnership boards. So they're They sit slightly above our clusters, but we want to ensure that they've got the right data, the right intelligence for planning, for making good planning decisions, that they're looking at all of the resources that are allocated to a particular area, that we've got strong partnership arrangements and joint commissioning arrangements in place, and that we're also able to influence some of the partnership monies that flow down through the regional partnership board. So in order to do that, those pan-cluster planning groups over time will need a lot more delegated authority. You're going to hear a bit about professional collaboratives in a moment, but we feel this is fundamental to the model. So this is about frontline professionals, people that are doing the work, that are seeing the problems, seeing the gaps in the system, that will have the best ideas and the best solutions. So we are bringing together community pharmacy, Opton, dental, allied health professionals, and nursing professionals into collaboratives to drive some of these community-based solutions. We think the focus for those collaboratives initially will be around issues like sustainability, how we redesign services for older people to help people maintain their independence and stay well at home, and how we deal with some of the current urgent care challenges. We also plan to strengthen the overlap between these integrated wellbeing networks and our clusters, and move the clusters towards producing business plans which go beyond the use of the monies that they receive for their cluster, and to take a whole life course approach. And then finally, we are keen to look at the synergy between what we're doing through clusters and what the Public Service Board is leading, particularly now that our Public Service Board in Gwent has committed to becoming a Marmot region, which means they'll be looking to tackle some of the underlying social determinants of health and health inequalities. So issues like housing and unemployment and so on. So that's where we're going next. I'm now going to hand over to Chiquita and Kerry. They'll be talking a bit more about the professional collaboratives for nursing and allied health professionals, and they'll be setting out a roadmap of how we'll be developing multi-professional teams further, and explain how we're going to be developing that community infrastructure. So next slide, please.
National Allied Health Professions, or AHP, lead for primary and community care. And I'm very pleased to be speaking with you today, along with my colleague Chiquita Cousins, the National Nurse Lead for Primary and Community Care, concerning delivery of a place-based model of care from our perspectives, and how the community infrastructure programme that we're driving forward supports this ambition. The Community Infrastructure Programme is one of the 4 key strategic priorities of the Strategic Programme for Primary Care, and a core part of its 24/7 work stream. Its ambition being to define the fundamental infrastructure required to deliver a 24/7 integrated, multi-professional, place-based model of care and support, focusing on how primary and community care services work collaboratively together, using the term professional in its widest sense to reflect all partners working across primary and community care. Recognising there's been huge amounts of really positive work in this space, but that it's often stood alone, not always joined up, hasn't had traction, with variation in terms of offer, description, access criteria, and understanding of services. This programme will identify the standards needed so that we have a repeatable, agreed and documented way of working together, with underpinning quality statements providing the specifications, guidelines or characteristics that can be used consistently to ensure processes and services are all fit for purpose. This is about raising the profile of community services, having consistency of what good looks like for multi-professional working, with good information, data with purpose and outcome measures demonstrating value and impact. Enabling primary and community care to have an equal footing in discussions concerning planning and delivery of support to meet our population needs, both concerning the immediate challenges of COVID, whilst also supporting longer-term sustainability, improving the access, experience and outcomes for our population, enabling people to live well, closer to home through prevention, choice, well-being and independence. This infographic outlines the work of the Community Infrastructure Programme, its priorities for this year and how we plan to achieve them. This is the first of 2 infographics I'll be showing you, with this one focusing on the process of the work being undertaken, and the second one explaining what good looks like in terms of outcomes for the community infrastructure work. At the top of the page, we have the programme's objective: enabling people to live well at home through prevention, choice, well-being and independence. The key priorities for this year are listed in the box on the left-hand side of the screen, with areas that we plan to focus on next underneath. We started this work with an engagement event in late 2021, and that is our driving focus: engagement with colleagues, professionals and organisations across Wales to ensure the work we produce makes sense, is evidence-based and will help to inform and support practice, making a difference to the individuals we support. To help us achieve this, we are working in partnership with the University of the South of Wales, who are undertaking a literature review on multi-professional working. Alongside this, they will help us understand the things teams and services value when working as multi-professional teams, and develop a matrix which teams can use via action research to develop and strengthen how they work together. The key priorities are supported by task and finish groups, which is where the development of frameworks and quality statements will be done, and a key stakeholder group, which through its broad representation helps to sense check the work for task and finish groups, so it's meaningful to the teams and services using it. This second infographic describes how the work of the Community Infrastructure Programme will help us to reach our overarching objective and outcomes by describing what good looks like. This infographic is still in the process of being developed, but generally feedback has been positive from our key stakeholder group. The words in bold in the outcomes sections are translated into how teams and services will work and what people should experience. For example, seamless care in outcome 1 translates into identifying the person, an outcome-focused approach and partnership working. The infographic describes the structures needed to enable multi-professional working, such as shared access to systems, using data to inform practice, and having a shared vision. It also recognises the wider role of the community in supporting individuals to live well at home. The infographic will have links to both the Community Infrastructure Toolkit, currently in development, as well as to the ACD Toolkit and specific AHP and nursing resources. In order to deliver person-centred collaborative care and support within a place-based model of care, there must be a clear line of sight between the Regional Partnership Boards, or RPBs, and frontline service delivery. This slide is a summary of the vision to achieve that line of sight, with professional collaboratives ensuring local knowledge, skills and expertise inform the decisions made at each level of that geographical operation. Professional collaboratives are about bringing professions and professionals together to assess population need for their respective services, consider the quality of their service offer, and look at how they respond. In a survey undertaken last year by the Strategic Programme for Primary Care, AHPs and nurses told us they were frustrated about the lack of influence across that line of sight, from cluster level to the wider geographical levels of operation. Their respective professional collaboratives will now ensure that the voice of AHPs and nurses can influence practice and enable people to receive the best outcomes, working with other professional collaboratives to share issues, priorities and proposals for solutions across that line of sight. In June, we held a workshop with nursing representatives across adult and children's services to discuss nursing professional collaboratives. We started by asking how, as nurses, we could work together, recognising that we don't always come together across our different organisations or areas of practice. The group emphasised the importance of open and honest communication based upon a shared vision and objectives, enabled by protected time to work collaboratively together. The group told us that a shared vision needed to be inclusive, person-centred, outcome-focused, and empower nurses to advocate for their local populations, utilising the strength of nurses skills and voice. The group felt there was an opportunity for nursing collaboratives across Wales to have some consistency in the key areas they should focus on, and these included, amongst others, a focus on prevention, reduction in inequalities, and retention satisfaction of nurses working locally. For professional collaboratives to be successful, the group noted they would require clear structures, meaningful outcomes, and opportunities for all nurses to have an equal voice and contribution. This would need to be underpinned by leadership development and peer support. In terms of developing nursing collaboratives across Wales, the group were keen on increasing nurses' understanding of what a professional collaborative was, so nurses could understand the value and opportunities the collaborative could bring, and to use local workshops as a way of agreeing how these would work practically within their health boards. AHPs are 13 unique professions allied by their belief in the importance of enabling people to live the lives they want to live. And in our Allied Health Professions Framework for Wales, Looking Forward Together, we identified our ambition is for well-integrated services rooted in the community with the full range of practitioner levels and prudent optimisation of AHP skill set. Currently, we have many examples of innovative AHP services providing direct access, early intervention, community rehabilitation and reablement, and complex treatments in primary and community settings. However, these are not yet available in consistent and comprehensive services to meet our population needs. Consequently, people who need the expertise of AHPs to maximise their health and well-being or improve recovery cannot always directly access us early enough. Additionally, we're underutilised in prevention, public health and primary healthcare settings where we could do more to help enable people to live as independently as possible for as long as possible in their own homes. Recognising AHPs have a unique perspective they can bring towards the development of services that support the needs of our population and deliver a place-based model of care, it is important that our collective perspective is heard and that with other members of the multi-professional team, we can influence the way we work together and provide services that meet both individuals and communities' needs. Fundamentally, there is a requirement for AHP leadership to be system-wide, present, strengthened, supported and developed. This is crucial to support collaborative decision-making, inform priorities and prudently allocate resource. Recognising that new AHP models and approaches require a transformation of the way we organise services, partnered with an expansion of the AHP workforce and the development of skills and range of services offered. The Primary and Community Care AHP Workforce Guidance, Organising Principles to Optimise Utilisation, is fully aligned to accelerated cluster development in order to achieve this ambition, with the development of professional collaboratives enabling AHPs to provide cohesive, collaborative and compassionate leadership, motivating, empowering and enabling us to work collaboratively and effectively with others, retaining the very best of existing practice and supporting the AHP workforce to achieve its full potential. Our National Workforce Workshop in June this year provided similar themes to the nursing one described by Chiquita, and we're using this to develop a clear national agreement on how the AHP professional collaboratives will function. This is also currently being translated across regional footprints via a series of regional workshops, supporting a uniformity of approach but enabling flexibility concerning local operationalisation. We hope this has been helpful insight regarding the delivery of a place-based model of care from our perspectives and how the Community Infrastructure Programme supports this ambition. To follow progress or get involved with the Community Infrastructure Programme, both Chiquita and I would welcome your contact.
So that concludes our presentations for today, and I hope the presentations have illustrated our commitment to place-based care. We want to work collaboratively with partners I've done much of that work already, but we know we have a lot more to do. And today's session is really important to connect with a wider group again. So we would really welcome your questions in the next part of this session, not just to clarify understanding of anything we presented today, but to challenge us to really make sure that what we're doing is on the right track and to make sure that we're thinking about everything that we need to be thinking about. So thank you very much. And I'll hand back to Darren.
Thanks very much, Sue, and thanks very much to colleagues for your presentations today. It's always really helpful the way you've set this out at the sort of strategic policy level, then hearing from Karen about the clusters, then Will locally on the ground. But I think the bit that's sort of landed for me is the huge breadth of professionals, individuals and organisations involved in clusters. You know, all of us working in health and social care realise that primary care is at the heart of these communities, and it was a great overview from you all. I'm going to ask Alan to come in and say a few words, and ask the panelists to put their cameras on so that we can see you at the top of the page, but still to leave your mics on mute if that's okay, so we don't get any feedback. I know, Alan, you wanted to just set the scene for us before we open to questions from the floor.
Great, thank you very much, Darren. It's unusual for me to be quiet for an hour and a half, I have to say. So I really just sort of just picking up on that video that Will showed us in relation to Ringland and the involvement of many partners. I was going to ask Will a bit of a question, really, as you further develop your clusters, your NCNs. What sort of approaches are you going to take, particularly with the local authorities, to kind of get those vital relationships really singing? Because it showed in that video that having those relationships between many people and many departments within the local authority, for example, that's actually what made a difference in there. So be useful to hear your views and thoughts on that, Will.
Yeah, thanks, Alan. I mean, the local authorities are absolutely key to cluster working being successful. We've actually got since the elections in May, 4 of our 5 cabinet members are new into posts, so they'll be getting to grips with the portfolio for social care. The Regional Partnership Board are putting on an induction programme for them at the moment, so we're helping to help them to orientate the partnership landscape and sort of demystify what clusters are all about. We've got very good relationships. We've had really good relationships actually over the course of the pandemic with the Directors of Social Services and heads of adult social care, making sure that we were, trying to protect the most vulnerable in our population. I think those relationships will just get stronger as we move forward with this programme. But there are other departments within the local authority that are absolutely crucial. So you saw Keir Duffin there on the video clip. So he's actually head of regeneration, investment and housing. He's responsible for the community development team. So when we're looking at social prescribing, we're looking at mapping out what our wider community assets are and where the wellbeing activities are happening. Those departments in the local authority are absolutely crucial. The third party involved with that regeneration programme in Ringland and Newport East is Newport City Homes. They're a housing association. They're completely transforming the town centre or the shopping centre in Ringland, and there's a huge amount of new housing development happening. So what we wanted to do is to look at all of those assets, that how we can work together to regenerate the area as a whole. And the idea is that we'll have a kind of community campus where all of those services, all of those resources that improve people's well-being, including the new health centre, are all linked together, through the cluster, and the cluster is a vehicle for doing that. So, although you might think it's colleagues in social services that are absolutely key for people with care and support needs, but it's those wider departments in the council, in housing, in regeneration, and community development that are equally as important with this, in my perspective, from my perspective as a cluster lead.
We sometimes forget that, don't we? How important those other departments are, because our main interaction is with social services or education occasionally, but the wider bits absolutely critical. So the approaches we've been taking around this, you see us really being able to accelerate what we kind of do. Will, would that be your thoughts?
Yeah, absolutely. And I think we've had a letter from the minister, where she's expressed how important she feels cluster working is for delivering a healthier Wales. I think that letter went to the leaders of councils and to local authority chief execs as well. So I think the signal is out that we need to be working in this way. So, and we're trying, as I said in the presentation, I hope it came across, is we're trying to marry up that place-based approach to well-being with a place-based approach for providing care and support.
Thanks very much, Will, and Alan. I think through the pandemic, we've seen a huge increase in how closely local authorities and the NHS are working on. And as you say, it is wider. We immediately think of social care, but it is much wider than that. I just wondered if you had any tips, because we recently had the local elections in Wales and elected representatives. There's been a big change and a big turnover. So cabinet members within local authorities with the responsibility for social care in particular. So are there any tips from Newport and your area, how you gone about building relationships with local authority, elected representatives, as well as delivery colleagues?
I think you have, shall I answer that one? I think you need to go into that environment. So, you know, I know Jane Mudd, who's leader of Newport City Council, you know, really well, and, you know, the former cabinet member, Councillor Cochrane. And I think, you know, putting on members briefings, you know, I will always make myself available if there's a scrutiny meeting at 7 o'clock in the evening, so I can talk to scrutiny members about the things that we're doing. And I think it's just about entering that world and making yourself as accessible as possible, and trying to overcome the kind of fortress mentality. You know, this is not about the health board trying to sort of address its own organizational pressures. It's about doing what's right for the population and what's right for the public and people and people in those communities. So that's the way I've tried to approach it in Newport.
No, thanks very much, Will. Any other thoughts or observations from colleagues on the panel on that one? I think I was going to go to Karen first, and I'll come to Sarah just for a view on sort of workforce challenges. That, you know, we heard a lot about workforce challenges in health, but I know there are enormous challenges in social care as well. But Karen, I'll come to you first.
Thanks, Darren. Yeah, I think to follow that up, and I could see one of the questions in the time bar is around sort of income issues, and that I think brings in our links with local authorities and third sector as well. And we know that a lot of the things that come into primary care have not a medical label, if you like. There's an underlying socioeconomic issue, and the Marmot link that Will talked about is all about that real gradient of inequalities, and that's what affects people's outcomes. So I think it's just that we're getting better at recognising that. And then from a sort of sustainability angle from primary care, recognising we need to not medicalise those problems, but get people to practical solutions. So much closer working with citizens' advice, you know, much better recognition of the importance of well-being and mental health issues that support that. And so actually being able to have those conversations about what a solution could look like and how could we do that at local level, and actually making it easy for people to just do that in one contact and not have to, you know, then face challenges of transport and those other things, which again further disadvantage the most vulnerable. And there's lots of examples of work with third sector particularly that we're sharing with colleagues.
No, thanks very much, Karen. And I think in the NHS, Welsh NHS Confederation, we've been looking at the wider determinants of health a lot. And as you say, it's more than about health. So we've been looking at building relationships on behalf of the NHS with people with a hand on the lever on some of these things, as we've described it. So a much wider relationship. If we're ever going to get into the prevention space, that's where we need to be. Sarah, a view from you, particularly around the workforce issues, and I'll come to some of the questions in the chat.
Brilliant. Thanks, Darren. And I think probably just to emphasise first the points that Will made, that this is definitely more and wider than health and social care, but we're also trying to make sure that element of the system is also working better, because we're not there yet. So totally support what Will said, and looking really at the whole of a community and the assets that it's got, and how we can work collectively together. And we've been doing some work with a whole range of partners on resourceful communities, and what some of the principles are for resourceful communities that I know we've shared with the primary care programme, and had really strong contributions from the third sector to really help us think about, well, what are those principles that we need to try and support and enable resourceful communities. In relation to the workforce, and I know that sort of cost of living pressures have come up in the chat as well, and we are facing, I think, probably across the whole of the economy, workforce pressures at the moment. We've got the highest level of vacancies that we've seen, and I think for me that probably has a disproportionate impact on social care in particular, because we tend to have a long-standing recruitment challenges for certain aspects of our work. There is now the Social Care Fair Work Forum, which is looking to tackle some of those really underpinning challenges. So the National Living Wage is now in place for the care workforce and or certainly being rolled out at the moment, and that's a good start. We probably need to go further to ensure that individuals are being remunerated for the expectations that we have on them as a service, and to really support citizens in communities fully. So we are experiencing some really significant workforce pressures at the moment. That puts a further challenge, I think, on programmes such as accelerated cluster development and community infrastructure, because we're asking people to think and do differently at a time when service pressures are really high, and they're endeavouring to do their very best for individuals and families. So there is a tension there that I think we need to be just cognizant of as we're moving forward on this work.
Thanks very much. And the cost of living crisis that Karen alluded to, there's links there obviously to the cost of housing, which has a big impact on people's health and well-being. And we in the Welsh NHS Confederation have been pushing Welsh Government quite hard on increasing salary rates, particularly for the lower paid and colleagues working in social care. And they moved forward, and we've been quickly overtaken by inflation and the cost of living crisis. There's really a helpful question from Fiona at the WCVA on the side, which very much feeds into this, is how can we maximise the contribution of third sector organisations and volunteers in promoting health and wellbeing, and thereby relieving pressures on statutory services. So I'll come to Sue first on that one, if that's all right.
Yeah, thank you. Really good question, really good point, and something that we're only talking about this morning, really, in terms of actually the connectivity and how do we connect conversations together. And part of what Will talked about in terms of kind of pan-cluster planning groups, I know that's a bit techie in terminology, but it's actually how do you pull people together to have conversations? And what we're trying to do through that mechanism is actually understand what our population, the local population needs, what the local population has, what are the deficits in there, who can be doing what, and who's best placed to do it. And third sector absolutely has to be in that mix and having those conversations. And I am going to just pass over to Alan, because I think Alan gives a really good example of the very first pan-cluster planning group meeting that happened, and actually how we're starting to think in this way. And this is exactly where we're going with accelerated cluster development.
Alan.
Thanks, Sue. Yeah, I mean, we are very clear that in pan-cluster planning groups that the cluster leads have got a seat round the table, and they don't at the moment. They don't get involved in that kind of level of detail. And equally that people from the third sector, so the third sector organisations and the community health councils are part. We weren't quite sure how that would play out. I had the pleasure of being at the first of the Swansea Bay pan-cluster planning groups, Swansea City Council, Neathport Talbot Council, and colleagues from the NHS, cluster leads, CHC, and the third sector organisation, and they played a fantastic part in terms of what they could bring to the table and pushing the ambition forward. So much an issue that they really can't do. To some extent, the third sector has managed to do that through the umbrella organisations like the WCVA and the local county ones in the RPBs, but this is actually getting into the teeth of it and bringing what they can, their influence to the table, but also seeing how those connections can be made. And it was great to hear in the very first one in Swansea Bay how vocal they were and how keen they were on this kind of bit, and how they could see this developing quickly over time with real ambition.
Yeah. No, thanks very much for that. It's been, amazing, the contribution that the voluntary sector made. And as you say, that sort of boots on the ground there in and amongst and part of those communities do make a huge difference. I'll come to Will and then to Karen. I think Will had his hand up first, and then I'll come to you, Karen. Will? You're on mute, Will.
It was bound to happen. It was bound to happen eventually. So if I say the professional thing first before the corporate thing. So I think more funding going into the third sector, they play a vital role. And I think we forget how difficult it is sometimes for third sector organisations to keep going. We've noticed that, I think, in the aftermath of the pandemic. So we've been looking at how we encourage, some of our third sector organisations to work together, to look at how they can sort of share some of the management costs, how they can share the use of facilities and things. And I think there was a huge amount of civic activity actually during the pandemic, and it's how we build on that. But some of our community organisations are still really anxious about reopening back up and how they can support people get to get back to community life again. And so we have put some money into that through our integrated wellbeing networks. The other thing we're doing to try and sort of build more assets and come up with community-led solutions around wellbeing is we've just launched a program, or last couple of years launched a program around participatory budgeting. So we've allocated money through those place-based wellbeing collaboratives, so the communities themselves have their say about how the money gets spent. And what we found is that sort of the projects themselves are obviously very worthy in their own rights. It stimulates a lot of community-led action. It helps the community sort of form a collective voice about what they think are the issues in their area. And the other thing it does is it sort of builds better trust in public bodies, which I think is another important sort of byproduct. So all the councils have signed up to that. The Gwent Public Service Board is, in fact, I took a paper to them just the other week. What we found now is that some of the other public sector organisations like Natural Resources Wales and the councils themselves, particularly Newport, they've put in £500,000 into participatory budgeting this year. They're starting to invest in that because they realise that actually the communities come up with the best answers to the things in their area. So that's what we're doing, at least.
Thanks for some really good examples there. And part of the aim of these events is to hear that good practice going on the ground and working and proven to be working in communities that can be shared around Wales. And I think that's one thing that we're keen to support, and perhaps something we as a country are not always the best at. The more people you speak to, the more you hear of really good stuff going on, but we've got to spread the word on it and support and share learning. Karen.
Thanks, Darren. Yeah, it was just really to give a very practical example, which I think picks up on Joanna's question in the sidebar, which is around some of the work that's been done on supporting people who are experiencing domestic violence. It's really interesting for me because that has come up in different areas across Wales from different aspects of the system. It might have been a police and crime commissioner, it might have been a nurse, it might have been a cluster. And it's enabled those local areas to say, that's really important practice and it seems to work over there. Can we try it over here? And then the cluster budget allows that to be tested, and it unlocks the link between the health service and third sector expertise, which is phenomenally effective at actually supporting that very vulnerable group. And then through the pandemic, obviously, there was a real need for those sorts of services. So I think there are some really good examples of how that suddenly we really get the power of the system when we can make those connections happen.
Thanks, Karen. A really good example there. And in relation to Joanna's point on the sideline, that's something we'd be keen to support after this, is sharing some of these good practice examples that Sue and colleagues and some of you as delegates might have access to. Really keen to share them. There was a point in the sidebar again from the development of new roles. I can't see the person's name, I'm afraid, but the question is, my concern is, where will the staff with the right skills come from? And have we linked with HIW about increase in commissioning places? I can see Kerry and Sue. Kerry beat Sue to the draw on the hands. It's a good job it's not a game of snap. Kerry.
Thank you, Darren. And I'll try and answer this from both mine and Chiquita's perspective. Chiquita being the nurse lead who wasn't able to join us today, hence the pre-recorded slideshow from us. It is an exciting opportunity with regards to new roles, but it's also about the opportunity to really look at the skill set that we've got and really look at our workforce in totality and ensure that that skill set is maximised in terms of improving people's outcomes and is in the right place in a timely way, responding to people's needs. And the link through to HIW is absolutely there as well. There's a primary and community care education framework in development, multi-professional working, so very much a partnership there as well across all stakeholders. But from an AHP and a nursing perspective, we have a huge range of skill set that I would suggest is a real opportunity there in terms of meeting population needs. But it's about how we look at our workforce in totality and how we organise it in terms of that place-based model care.
Thanks very much, Kerry. And I know that working with colleagues in Health Education Improvement Wales, that sort of whole workforce plan, not looking at things as perhaps they've been looked in the past, where you decide X number of doctors, X number of nurses, X number of pharmacists. It is about the whole team. And I know AHPs and your colleagues have been very vocal in pushing that forward and making really big steps. Sue, then Sarah.
Yeah, I won't repeat what Kerry has said so beautifully, but basically I would want to absolutely reinforce that we
we're working hand in glove with HEIW on this. They're part of our workforce work stream. They have been very responsive in terms of what we're hearing from service and therefore what we need to put in place. So I just wanted to reassure people that yes, that is an absolute partnership in terms of what we're working on. And I won't steal Sarah's thunder, but Sarah's part of that group as well. So I feel that we're working really well in that area, and an absolute commitment from HEIW on it.
Thanks very much, Sue. And I think flying the flag for Wales, I think we were the first country with Social Care Wales and HEIW looking at its health and social care workforce plan. We've still got some way to go on delivery, but there is a plan. Sarah?
Yeah, so that's what I wanted to mention really, Darren, was the 10-year workforce strategy for health and social care. So that it was launched during the pandemic, although all the engagement with colleagues happened prior to that. And we're just now, we've had one event, we've got 2 next week and 2 digital events in September. Social Care Wales and HEIW are inviting colleagues from across the whole of the health and social care sector, including education, to help us look at the medium-term implementation planning now for the workforce strategy, what needs to be the next step. So this work sits firmly within that too, in terms of the workforce elements, where we're looking at how can we have more seamless work models, how can we support recruitment, retention, education and training, workforce planning. All of those elements are covered, and some of the primary care work has been a key action within that. But we are trying to look over what needs to happen in the next 3 years to achieve that 10-year ambition that we initially set out. So all of that work is interlinked. It's fairly complex in terms of what we need to do with the workforce. As Kerry said, it's about supporting and developing our current workforce, as well as recruiting in new colleagues for the future too. So we're definitely on that journey, and we'll continue to make the links across as all this work progresses.
Thank you, Sarah. And I think working with yourselves and HEIW could be an excellent idea for a Wellbeing for Wales webinar in the not too distant future. There's another question from this time from Craig Lawton of the BMA. You detailed that there's a peer review of cluster working planned towards the end of the year. Could you give some detail on what engagement is planned with frontline staff and patient representative groups as part of this? I'm guessing this is probably one for Sue, is it, to start with? I should have waited for somebody to put their hand up, would have been a politer thing. Actually, Karen had put her hand up there. Saved by the bell, Sue.
Yeah, I'll volunteer, but Sue may want to add to it. So yeah, we're running a small scale peer review program towards the end of the year. So it's just one volunteer cluster from each of the areas, just to test out the process. It follows on some really helpful cycles of peer review through regional partnership boards and through our out of hours services. And it's really trying to capture the reality of what it's like to work in those settings. So I think the question was around engaging frontline staff and patient representatives. I think for us, what we're trying to do is to get people working in clusters, talking to colleagues who are working in another cluster in a facilitated discussion. And one of the questions to them will be, how do you engage your workforce? How do you engage the public? So it's testing how they have those systems working day to day. And then we'll be looking at, the peers that they're talking to will be able to compare that to their experience and the wider Welsh experience. And then we will be using that to inform the kind of ongoing process. So those principles are in there, but it's not about actually going then out wider. It's very much about a peer-to-peer discussion and what you want to do, what's stopping you doing what you want to do, and how we can help that.
Thanks very much, Karen, and thanks very much, Craig, for the question. On the issue of workforce, we sort of touched on earlier. The General Medical Council, and I know the Nursing and Midwifery Council, and I know other clinical regulatory bodies have started to crunch a lot more data on this. And what we saw through the pandemic was, the rate limiting factor in terms of being able to look after and care for people was workforce, numbers of people, the skills that they had. And some of the data I've seen recently is quite scary in the age profile of certain professional specialities. And workforce, training of the workforce, is devolved to Wales, but we're also dependent on colleagues from other parts of the UK. And I was quite shocked how increasingly dependent we are on colleagues trained abroad, internationally trained people. There's brilliant work going on at HEIW and with Social Care Wales on some of this. But is there a message for government on this one, on where priorities need to be in terms of training to equip all of you involved in clusters and community work across Wales? Is there one ask for government on that one? I'm being a bit cheeky asking that question as chair of this meeting. Sue?
So never want to miss an opportunity, though. I do think, I agree.
I think there is something about actually, you know, the learning that we got from COVID and the pandemic, and the need to have a really resilient primary and community care infrastructure, and that, and when I talk about that, I talk about that in the widest sense as ever. You know, what do we have outside of hospital to support our population? So I think, you know, that argument is there and made through the pandemic. I do worry we shift back when we see waiting times and we see kind of the ED, the 999s and that kind of thing. I do worry that shift might happen back. So one thing for me is about holding that space, really, about the real importance of growing this. There is a plan here, there is a program here. It's certainly, you know, something that we can move into in terms of that space. But I suppose the other bit for me around, and it's less about the training and the skills, is we've got a good narrative in Wales. We're not really sharing it. So building that narrative about what the offer is in Wales, how we work in Wales, you know, what we can do going forward, that multi-professional team working, that place-based care approach. It's a small country, you know, all those kind of things that we can do. I don't think we sell ourselves as well as we could do.
Yeah, thank you. So Karen?
Yeah, I think the principles are in there. I think one of the things that, Darren, that we've really included in all of the work around the cluster was workforce experience.
Yeah.
So that's become more and more critical, because retention is really, you know, a key part of our sustainability. So it's all about helping people only do what they need to do, but it's making it easier to do their job. There's also some specifics though around new models like community interest companies at cluster level, which allow people to be employed. So there's some really practical things that, you know, are getting in the way of people coming up with solutions. So those are the sort of practical things I think that we want to really push for, is encouraging the front line to suggest solutions, but take all of the nonsense out of their way when they then try and put that into practice. So if we could keep doing that, I think that's critical.
Thank you, Karen. I don't think you'd find anybody who would disagree with that. Sarah?
Thanks, Darren. When we did all the engagement on the workforce strategy, the one common consistent point that was raised, and probably strongest in its feedback, was the importance on the well-being of the workforce. Yeah. So it links through really well to what Karen was saying on retention, but the feedback from the workforce is almost, and I'm paraphrasing, we're expecting them to care for really vulnerable individuals in their communities and to empower them and support them to live really independent and quality lives, yet they don't always feel cared for by their employer, and whether, regardless of who that employer is. And so that importance around wellbeing in its wider sense, and in that we can include being appropriately equipped, being empowered to do a role, and being given appropriate remuneration and so on, and being treated equally compared to peers, came through really, really strongly. And so that emphasis on wellbeing is really, really important that we don't lose sight of.
No, thanks very much. That's a really good point. And in conversations you have with colleagues at NHS Wales employers, it is that sort of well-being is where things are, is looking after and developing the workforce that's already out there with a huge amount of skill and experience, is how we enable them to keep doing the best that they can. Kerry?
Thank you, Darren. I just wanted to perhaps build on comments a little bit in terms of certainly my lens, where the Accelerated Cluster Development Programme, the Community Infrastructure Programme, the Strategic Programme for Primary Care is hugely important in terms of building on and setting that direction strategically. From an AHP perspective, we're not looking at a specialist layer of AHP workforce that releases capacity in one part of the system and blocks another. It's a whole system approach, and this really is about that whole system approach and maintaining that shift that Sue spoke about to deliver place-based care. And we've seen examples over border in the other nations where they've had that opportunity to directly employ or have funding for a layer of primary care, but without strategic whole system approach, and it's led to workforce burnout, or perhaps not optimised in terms of utilisation. So the direction we're setting here in Wales and building on is absolutely the right one, certainly from an IHP perspective.
No, thanks, Kerry. That's really, really good to hear. I'll come to Alan, who's got his hand up, but we've got about 8 minutes left. So if there are any delegates who are keen to pose a question, you're coming up to Last Chance Saloon for questions in the sidebar. Alan, over to you.
Thanks, Darren. I've been too slow to get my hand up on a couple of occasions. Just want to make 2 points really. The first was around when we talk about the peer review, and Karen very eloquently outlined what we're doing there. But we're involving the regional partnership boards in those peer reviews as well. So it's not just about cluster to cluster, but it's actually having the regional partnership boards, our colleagues from the regional partnership boards involved there. So we can test out, is there anything happening there? Are there linkages between what cluster level from those frontline clinicians and then what's happening at an RPB level? It gives an opportunity also, I think, for some of those RPB colleagues to really understand what is happening down at cluster level. And I think we've, as Sue and I have talked, and others around, and Will, we've talked to colleagues, and sometimes they say, we've missed a trick there, or we've missed a trick around that cluster work. And I think the whole programme has begun to enliven that with a far wider audience. I think that's a really good thing. The second bit, and I think Sarah mentioned it in terms of just that equality of voice, etc. Again, the Accelerated Cluster Development Programme and community infrastructure is about trying to make sure that primary and community care services and clinicians have got that strong, equal voice around the table in terms of that planning and decision making. Far too often, the strong voice is in that secondary care space, and primary care is the also ran. This is actually putting primary community care services front and central in terms of what we're doing. I think that again is really important that they've got an equal to social services, equal to local NHS leadership, equal to those in mental health and secondary care services. So I think there's a real job for us then, making sure that we then support those cluster leaders and those leaders that come forward in the work we've been doing with HIW so they can really perform in that kind of space, because some people have never done that before, and it's going to be quite an ask to get people to get into those kind of quite difficult environments, quite challenging environments, and negotiating environments. I think we've got work to do there, but I think if we can make that work, we'll really have primary and community care services singing from the same quality of voice.
No, thanks, Alan. I think some really good points made there within the new structures. I think it is vital that the primary care voice is heard, and I think it's a frustration of ours in the Welsh NHS Confederation that if you're engaging with the media or with politicians, they always want to talk about hospitals. If it's the media, they always want a picture of ambulances outside a hospital. And obviously, primary care has got a huge role to do in keeping people well in the community, and that sort of prevention, keeping people well in association with everybody involved in the cluster, everybody involved in social care. But we try hard and really keen to work with you on that going forward to give primary care much more of a voice around the decision-making table. So some great food for thought there for us as well. There's one final question in the sidebar before we run up, and it's in relation to sustainability of funding, which again is something you'll have heard us calling for in the Welsh NHS Confederation. There is a huge amount of money does go into the NHS and into social care. But what we don't have is that certainty going forward. What will the funding settlement be like in 3 years? How do we invest today to train care professionals who are not going to be making their maximum contribution for 5 to 10 years time? And it's very much in relation to social care, voluntary sector. And feedback from voluntary sector colleagues, as we said earlier, made a huge difference through the pandemic and continue to make a huge difference. The challenge for them is around that certainty of funding going forward, and I think things are likely to get tighter going forward. So I'm trying to frame this into a question now. What do you think needs to be done to ensure that for yourselves, for voluntary sector colleagues, for social care, needs to be done so that there is a sustainable funding plan going forward? Sue and Karen, I didn't spot whose hand up was up first, but both pretty fast. You're being polite now. Go on, Sue.
I'll start. I'll be very brief though, because I know we're running out of time. But so my view of this is that
primary care, so Alan talked about cluster funding, community care, the variation that we have, third sector, it all tends to be ad hoc temporary funding. It's not baselined, it's not consistent. So part of this is about saying, okay, on a pan cluster footprint, what's the totality of the resource and how should we deploy it going forward? And that's the kind of thinking we need to get into, and not the piecemeal bit that we have been doing with the development of primary care incrementally and community care incrementally. It must be much more broader in terms of the way we think about this going forward.
Yeah, if it was on Teams, then I'd have done a clap symbol on the sidebar, but I don't know how to do it on Zoom. Karen?
It's one of the strongest feedbacks we get from clusters is the frustration around short-term funding. I suppose my point around that is clusters are designed to test new models. So actually you can be a little bit more flexible, but what they need to be able to do is mainstream. And that's an area where we're work in progress. Will mentioned we really look around to see other models. One that stood out for me was the Bromley by Bow, where because they have such a very good understanding of the need of their community, they have an absolutely crystal clear plan. They then work behind the scenes to sort the money out, but it doesn't get in the way of the teams that are actually doing the doing and the understanding. And so there's some smart things around that, I think, of getting the right people worrying about the money and allowing those who are doing the design and putting it into practice not to get pulled away from that. We could always use more resource, but I think the idea of having a real plan around real community means you're always ready for any next source of funding to put that into good practice.
Thanks, Karen. And finally to Will.
Yeah, just to build on what Karen said, when I went up to Bromley by Bow to meet with Sam Everington and the team up there, he was quite humble actually. He said, primary care is just a very small part of the Bromley by Bow Centre. They're a £4 million social enterprise. They're a magnet for money. The people who've got long-term conditions, who are suffering with chronic pain, their lives are improved if you can meet their social and emotional needs. So I think we should be supporting third sector organisations to measure the social value they provide. And that's absolutely what they were doing in Bromley by Bow, and the Well London programme. They sort of tried to tie all these different funding streams together. We're literally going out door to door. They had patient advocates out in the community that were finding out what the needs were, and then constantly feeding this into that social enterprise. So they were constantly evolving to meet the needs of the local community. But actually, the primary care offer was a small portion of that. In fact, their waiting room doubled up as an art gallery, and the practice team were right at the back of the centre. So yeah, so it's a great model.
I had the pleasure of meeting Sam Everington, who came to speak at our conference a few years ago. He's a great advocate of cold water swimming. So all of you from Gwent, I'm expecting you to see swimming up and down the Usk now in the coming months. But thanks everybody for a really, really fruitful discussion today. People are engaged, and as is always the case in these things, you have lots of questions in the last 2 minutes or so where people weren't typing away. But we will come back to you and address all of those. Just like to thank on everyone's behalf everyone who's made a contribution today. Very, very wide-ranging discussion. Great, there's some sort of commonality of challenges that have come to the service. We're keen to work with you all going forward to highlight the good work you're doing, share that best practice. It's a big part of what we do at the Welsh NHS Confederation. Just a reminder that we have got unusually another event next week. Why good housing is essential to health and well-being, and we've touched on quite a lot through the conversation today, the importance of the wider determinants of health. Please don't forget to tweet about the event today. And the big ticket item for us is we are having our face-to-face Welsh NHS Confederation conference in September, which is a great opportunity to showcase this work and many others, and look forward to seeing you all there. Thanks very much for the delegates for attending. A really good turnout. I think over 75 as I was looking, and we will come back to you with answers to as many questions as we can on the sidebar. And the very final one, if you've got a good idea for a topic that we should be covering as part of these ongoing lectures, please do get in touch. Thank you all.